Welcome back. Dr. Walter Lin, one of the PTAC members. Chinny and Lee laid the foundation for this public meeting and some of the questions we want to explore. I am excited now to welcome 5 esteemed experts to share their perspectives on approaches to improve patient safety in alternative payment models. You can find the full biographies and slides posted on the ASPE PTAC website and the public meeting registration site. Welcome to our 3 in-person session participants. And for our remote participants, please go ahead and turn on your video if you haven't done so already. After all experts have presented, the committee will have time to ask questions and engage in what we hope will be a robust discussion. First, we are pleased to welcome in person Ms. Susan Sheridan, President and Chief Executive Officer for Patient Safety US. Sue, welcome.
Thank you. Good morning to all. And I really want to share my appreciation to those of you who actually invited me to present today. I don't know how often you hear from patients or the patient community, but I'm extremely appreciative, and this means an awful lot to me and to millions of patients in our nation. As mentioned, I am with, I'm with Patients for Patient Safety US. We're a national organization. We're a large convener of patients, healthcare systems, HHS agencies, specialty societies to really address patient safety. We have over 200 patient organizations, community-based organizations, consumer organizations that work with us. Our mission, of course, is laser-focused on patient safety. So you can see here that, I'm with Patients for Patient Safety US. Currently, I'm also the co-chair of the National Academy of Medicine's Patient Safety in the Era of AI initiative. So that's probably another dialogue, but an important area to look at regarding patient safety. I was a director at the Society to Improve Diagnosis in Medicine. I was an advisor at CCSQ at CMS. I was a director at PCORI, the Patient-Centered Outcomes Research Institute, around patient engagement. And I also I was the external lead at WHO on their global Patients for Patient Safety program. But what brings me here today? Cal and Pat bring me here today. You can see them on the screen. Lightning struck twice to my family. 2 diagnostic errors in one family. Now, you were talking about errors of omission. These were 2 errors of omission. They're both now considered never events. Cal was born a normal, healthy newborn in 1995, but he suffered brain damage at 5 days old from the failure to test and treat his newborn jaundice. He has a condition known as kernicterus. Cal today is 31. He is hearing impaired, speech impaired, and mobility impaired. He's funny, he's super smart, but has challenges he should never have had. You know, what I learned is that Cal was born during the HMO area, the managed care area, and they did not give him a bilirubin test until day 5, and it was too late. And what I learned that broke our hearts was that there were actual incentives to the clinicians to withhold routine tests. The bilirubin test cost $1. 60 years later, you can see Pat up here. Pat died also from a diagnostic error when his malignant pathology of a synovial cell sarcoma got lost in the healthcare system and never communicated to the neurosurgeon or to us. It metastasized. It killed him when he was 45 years old. Cal was 6, and we had a little girl during that time, Mackenzie. She was 4 when Pat died. I was widowed at 42 with 2 little kids and $300,000 in debt because we had passed Pat's insurance limit. This was back in 2002. As you can imagine, I was terrified. But what haunted me more than anything of these 2 errors was the invisibility of what happened to Cal and Pat. There were no mechanisms collecting that information. That data landed nowhere. And in my attempts to report it, I realized there were no mechanisms for patient-reported experience and outcomes related to safety. What I can say with absolute certainty is that patients expect learning and immediate improvement from our losses. So the problem, Sam and the chairwoman, Chini, went through the problem, so I don't want to dwell on that, except I do want to highlight the diagnostic errors part of this, that diagnostic errors are the most common, the most costly, and the most catastrophic, and the most underreported harms in our healthcare system. It is estimated that it's costing our country annually $200 billion. And it disproportionately impacts our vulnerable populations, including my son. I also want to focus on the last box down there, that current APMs do not directly measure patient or diagnostic safety from our perspective, missing tremendous nuggets of information regarding diagnostic and patient safety, coordination of care, and delays in diagnosis and other issues. What we know is, if you can't measure it, you can't improve it. We know that. What we also know that CMS and CDC are calling on healthcare systems to directly learn from patients and families to improve our outcomes regarding patient and diagnostic safety. That is evident in CMS's new patient safety structural measure. And we've also learned through research that patients are actually very good detectors and reporters of harm. And I encourage you to take a look at some of that data. So taking all this into account, my organization launched Project Pivot. It is to improve patient and diagnostic excellence, especially in vulnerable populations, through the creation of patient-reported outcome and experience measures. We brought together over 100 patient organizations, community organizations, patients and families, and over 149 professional stakeholders, including key agencies that you'll see in a few minutes. Together, we ended up with quite a big bolus of potential survey questions or questions that patients wanted to be asked, but we worked together on we brought together a large stakeholder group. You can see up there CMS, HRQ, Press Ganey, Geisinger, ECRI, all who are speaking at this event. We're part of this prioritization and what patients really want to see. Now, these are 6 questions. They're currently in a process with Press Ganey that they're getting piloted and validated this year. We also have in the pipeline several other questions specifically around diagnostic safety that we're launching in September. But you can see that patients want to be asked about their experience of unexpected harm, both physical, psychological, emotional, and financial harms. They want to report when they're treated differently. Now, this was especially true for older adults because we have an older adult group in this project. During the hospitalization, did you feel that any of your concerns were dismissed? As my concerns were dismissed when I was reporting to the healthcare system Cal's symptoms and that he was changing before my eyes. They want to report, if they were informed, how to report a concern about patient safety. That also of importance is, were they informed how to escalate care or get a second opinion? And they also wanted to be asked if they were given a list of pending test results upon discharge. Now, all of these questions, Press Ganey has refined also to apply to the ambulatory care. So why are patient-reported experience measures, patient-reported safety measures so important? First is value. This measures what matters to patients. Second is transparency. This makes hidden harms and near misses visible, measurable, and actionable. Preventive. This is real-time patient-reported measures can identify safety risks before harm occurs. Learning health systems. Patient-reported measures are available immediately, and we don't have to wait for claims data to take action and make change. Accountability. Create C-suite accountability for patient and diagnostic safety. And integrity. Patient-reported outcomes are harder to gain. So based on those questions that I showed, patient-reported experience measures, and the current ACOs that we have, our first proposal is how, and the nearest term proposal is why not integrate these patient-reported measures into current ACOs. Now, I just put LEAD and the MSSP up there as examples. The benefit of this is that we already have an ACO infrastructure. It's a minimal burden, and I'll talk about this tomorrow at the last session, where this can all be, we can use AI to collect, analyze, and report patient-reported outcomes. This will bring patient-centeredness to the ACOs, a safety lens. It promotes diagnostic excellence, which is really missing in most payment models, and it will reduce cost. So tomorrow, I will be speaking about the pivot earn back value model, where this is a proposed model that instead of penalties, this is actually withholding if benchmarks aren't achieved. It's a withhold of money, like Sam said earlier. There's money on the table, and they need to show improvement, and they can earn back that money. So, I mean, patients rarely want to see healthcare systems actually penalized. The number one thing we want is learning, continuous learning. So in closing, regarding patient-reported measures of safety, patients and families have always been the earliest detectors of safety breakdowns and the clearest judges of whether care was truly safe. The question before us is not whether their voices matter. The question is whether we will finally value those voices enough to measure them, to learn from them, and reward health systems that respond to them. What patients experience is not peripheral to safety. It is safety. Thank you.
Thank you, Sue, for the passionate presentation. We are saving all questions from the committee until the end for all presentations. Next, we are excited to welcome back in person Dr. Michelle Schreiber, who is the Deputy Director of the Center for Clinical Standards and Quality and the Director of the Quality Measurement and Value-Based Incentive Group at CMS. Welcome, Michelle.
Thank you, and thank you for the invitation. It's really a pleasure to be here. I am a general internal medicine physician by background. I've been a chief medical officer, chief medical informatics officer, a chief quality officer, and I've been deeply engaged in patient safety and quality for most of my career. As a matter of fact, it's one of the reasons that led me to CMS. Doing no harm is the fundamental principle of healthcare, and we're very excited that you are considering a model that will really focus on patient safety. How did you advance here? There we go. I think you already know about the patient safety being a public health urgent model. This was certainly outlined by Sam and Chinny in their excellent presentations, and that you also know that there is a cause for optimism and that the results have been getting better, because during the pandemic, the safety metrics of this country plummeted. That wasn't just because of the cause of the pandemic and people were really scurrying to try and understand COVID and how to deal with it. I think it's a reflection that the systems of safety that we have put in place were not strong enough to withstand such a burden, and that we really need to focus on building our systems of safety. And while our numbers are getting better, they're just now recovering to pre-pandemic levels. They're not continuing to improve. At CMS, we have a number of safety levers that we have been employing. But I do want to say that, as was pointed out earlier, this remains a fragmented system. Even our own programs, try as we may to bring them together and integrate them, which we are trying to do, still remains somewhat fragmented, but you can see we have many of them. A large ecosystem has been put together in this country that is not only CMS. We work closely with CDC and AHRQ and FDA and ONC. But you can see just within CMS we have several, including the conditions of participation, which establishes the floor for quality and safety. However, here the penalty is so great. In other words, if you fail the conditions of participation, you cannot participate in CMS payment, which means that they're not invoked very often because the penalty is so severe. We have coverage and payment decisions. We have audits and evaluation. We have survey and certification, largely to the conditions of participation. The Quality Improvement Organization is one of the largest quality improvement organizations in the country, and they do focus on improving safety, largely focusing their efforts in skilled nursing facilities, small clinician practices, and smaller hospitals, and they have shown improvement. In quality measurement, it is true that CMS maintains a portfolio of quality measures, and we are transitioning those measures to digital measures, which we think will provide near real-time data, not just for CMS, but for organizations themselves to learn how to use their data real-time to create learning health systems. These measures are used within 27 value-based programs. Some are pay for reporting, some are pay for performance, and they cover virtually every healthcare setting in the United States. And finally, and I know Susannah will be talking about this, the payment and innovative advanced payment models. I did mention that we work closely with our sister agencies across HHS and external to HHS, in particular the VA and the Department of Defense. The measures, Chinny, that you had pointed out that CDC is putting forward are collaborative measures between CDC and CMS, as are many of the other measures, even with AHRQ. This works fast. CMS has done a number of things recently to advance accountability. You've already spoken of transparency, and as a matter of fact, you showed some of those results on Care Compare, where we publish all of our data transparently to the public. We empower patients to make informed decisions based on this, and we empower providers and healthcare systems really to see how they're doing. You may recognize that most recently CMS finalized that we will reduce star ratings by 1 star for any facility who ranks in the lowest quartile for patient safety, because we did not feel that someone should have a 5-star CMS sort of seal of approval if they were the worst in patient safety. That affected 14 hospitals this year, and when we do this with all hospitals next year, it will affect approximately 450 hospitals. We are deeply committed to technology and data, as I pointed out, transitioning to digital technology for all of our measures, but in particular our electronic clinical quality measures that are digital through FHIR, as are CDC's, for safety, so that organizations, again, can use these in real time. We're also looking at AI to sit as a layer on top of electronic medical records to be able to use large language models to pull more information, especially around patient safety, so that that can be used as supplemental information. It is also a potential source of looking at the incident reporting systems of most organizations, because these are separate in many organizations and we don't have insight into them. The culture of safety that has been alluded to is extremely important. It really provides support for reporting. And Sam, I would only say one thing to your comment where you said we should be penalizing for failure to improve. I would add to that, penalizing for failure to report, because many times these episodes go unreported. And finally, payment, we are talking about that today in terms of a model, but we have also been exploring whether or not the Center for Medicare has any levers to use for non-payment of error. We are limited by the regulations of the Deficit Reduction Act, but are still learning what we can do for payment. I've spoken of some of these accomplishments already, but CMS has put forward the birth-friendly designation. This is in support of maternal safety. The patient safety structural measure, which has been alluded to. Important information on this is in the appendix of these slides so that you can review them for details if you wish. The age-friendly structural measure is also one around safety, especially in the elderly. The Quality Improvement Organization 13th Statement of Work, and I spoke about the stars in our suite of digital measures, and we are starting with several new measures for diagnostic safety. In terms of quality measurement, you can see we have over 400 measures, and 122 of them are dedicated to patient safety, of which a large number are actually external to hospitals, although the major focus has largely been in hospital programs. The new focus is not only medication safety, complications, healthcare-acquired infections, but also organizational capacity, which is really what the patient safety structural measure was, and diagnostic safety. These are the 5 domains of the patient safety structural measure, and I do want to emphasize, although it has been stated before, the vital importance of leadership and governance when it comes to patient safety. It is truly that is a fundamental commitment to patient safety being the North Star that will help an organization really make gains in patient safety. And we see this across the board, and we see some organizations fail because their leaders have left. One of the things that really needs to happen, and we're very excited about this being considered a payment model, is that the C-suite, including the Chief Operating Officer and the Chief Financial Officer, have frequently seen this as a penalty that they're willing to take, rather than investing because safety is the North Star, investing in patient safety and making that better. I also want to highlight what Sue has been talking about, the vital importance of patients and family engagement, the ability of patients to report directly, the ability of their voice to be heard. We do have a suite of digital measures. You can see them here. And as you heard, partnering with CDC to bring forward more. Again, the goal here is real-time reporting that a facility can use to make continuous improvement. I think many of the successes and the shortfalls were really covered by Chinny in your really wonderful presentation, so thank you. I won't spend time on this. But I do want to just highlight a few future considerations. We've talked about the use of artificial intelligence, the reporting of harm. Many of you know that there is actually a national patient safety organization movement. There are about 100 patient safety organizations in the country, and they are in theory supposed to report to a national database that is maintained by AHRQ, which would give us national information around patient safety. Of the 100 patient safety organizations, only about 5 actually report. And I think that is another opportunity for us to have more national information around patient safety. We spoke about digital advance. So in thinking through a model, I just want to close with a couple of things. One is the hope that there will be one. And Sam, I want to thank you really for your tireless commitment to patient safety. You and I have spoken on multiple occasions, and I think your leadership has been instrumental. 2, focus on capabilities. Ensure that the system has the capabilities such as governance, the ability to use data real time to drive improvement, and the culture that allows speaking up and reporting in a safe environment. Include training in everything that you do, because a lot of organizations may think they have capabilities such as high reliability, but really when they think about it, they don't necessarily have it. Patient engagement, there's a tremendous opportunity, I think, to reframe and re-ask patients around their experience for safety. And technology offers us a lot of opportunities for the future, such as wearable devices or monitoring or predictive analytics and artificial intelligence to gain more information. But in the end, I think the most important thing is willpower. If we can create the will to change and to truly accelerate patient safety, there's no doubt that we can make tremendous progress and that patients will not be harmed. Thank you.
Thank you, Michelle. Next, we are also happy to welcome back in person Dr. Susannah Bernheim, Chief Medical Officer for the CMS Innovation Center. Susannah, please go ahead.
Thank you, Walter. Thank you. I'm really happy to be here this morning to speak with all of you and to be on a panel with colleagues who have just committed so much of their life's work to promoting patient safety. It's really an honor. Michelle covered a lot of the work around patient safety at CMS. I feel like my job here today is to talk a little bit specifically about the CMS Innovation Center, what some of our authorities are and our opportunities, and give you just a few examples of places where patient safety has shown up in our models to sort of spark the committee's thinking about where we could go from here. And I want to really appreciate and acknowledge Sue's concrete recommendation for us about ACOs and where we could go there. And Sue, I've heard your stories before, but sort of stops the room. I'm sorry and appreciate you sharing them. Okay, to put the bottom line up front about how I think about the Innovation Center and opportunities. If you look at the CMMI portfolio today, we don't have a patient safety model. But across the portfolio, you'll see efforts to use the levers we have, the distinctive levers we have in the Innovation Center to advance fundamental changes in healthcare. And a lot of those particularly should drive care coordination. And in fact, one of the main themes that came out of a 2023 study about common findings across different models was this common focus on driving coordination. And if you think about what leads to poor patient safety, coordination is a critical tool for improvement. Coordination and communication between primary care doctors and specialists, between ambulatory care and acute care, between patients and clinicians. So I think that is a key opportunity for us. And the heart of the Innovation Center work is a requirement that our models both drive lower costs and improve quality. Improving safety is fundamental to the success of our models. As many will point out, adverse safety events and experiences are not only terrible for patients, they're also costly for the system. And care coordination is a key gap that models can help address and is really crucial for safety. So I'm going to step into a short overview of this Innovation Center's priorities. I'm going to talk about the authorities that we have that can drive safety, give you a couple of examples from the ambulatory space. You'll see me really focusing on some of our ambulatory models because Michelle has done such a nice job thinking about the hospital space. And then really just hope to think about the opportunities in front of us. Oh, that was my agenda. Okay, so this is an image of how we framed the priorities for the center. And because Abe mentioned a bunch of this, I'm just going to take a moment on this. We have these 3 pillars around prevention, patient empowerment, choice, and competition. And as Abe noted, all of these have meaningful connections to patient safety, but I just wanted to say a word about our patient empowerment pillar, that one in the middle. I think following on Sue's remarks, there's been really important advocacy from patient safety experts about the need for us to empower patients and beneficiaries as a part of our efforts. In the Innovation Center right now, we're addressing patient empowerment primarily by focused on how can we give people more information, support, and incentives to take a more active role in their health, that equipping patients with the tools to understand their health status, set goals, make informed decisions is important. But I think this idea around surfacing information to beneficiaries is a really important and synergistic with the work to advance patients' voice in the health system, as both are really about the advocacy for patients, engagement, and partnership. I'm going to just switch now to talking a little bit about where I see our opportunities in ambulatory care, but I can't resist saying just one word about the hospital models, because I think they have been a tremendous opportunity to strengthen the incentives already in use in CMS. In TEAM, which is a mandatory transforming episode accountability model, we're focusing on surgical bundles. This will be mandatorily in hospitals across the country. And it lets us not only incorporate the patient safety measures that Michelle's teams use, but crank up the financial accountability for those measures. And it's really about driving coordination from the hospital through the outpatient space and holding hospitals accountable for those outcomes. And if you want to lower the costs of procedure-based bundles and reduce use of acute care and maintain good outcomes for beneficiaries, coordination and avoidance of complications are critical. And we've seen the success of bundle payments preventing decrements in patient safety in our CJR model as well. We could not have proposed to expand that model had we not had results that showed that these bundle payments could be successful. So that's my quick word on the hospital measures as I pivot to ambulatory. So this slide is just a reminder about some key ambulatory safety priorities and the opportunities that they afford us to try to improve safety. Here, like in the hospital setting, but even more, we see the importance of communication, medication safety, care coordination, failures, and the fact that patients need to be centered in their care. And this gives us these kinds of failures influence medication management, fall prevention, diagnostic safety. So I think there's a lot of opportunity in the Innovation Center and in advanced payment models to focus on interoperability, to focus on medication management, which we'll talk about an example of coordination, as I've mentioned before, our communication systems, especially, again, going through hearing from patients and engaging with them. And a note, as recommended by many, that we really focus on patients who are most high risk. So as we turn to thinking specifically about alternative payment models, I think it's useful to ground in what the Innovation Center's authorities are. So this is, I don't even know what all these sections refer to, but a reminder that what's sort of distinctive about what we can do in CMMI and what this committee can help us think about is the ability to waive existing requirements to test new approaches that can help us advance safety. And I wanted to give examples of the ways we do that, again, in the spirit of sort of sparking the committee's recommendations. So, for example, in some of our models, we waive the 3-day rule. This allows participants in the models to identify patients that would benefit from skilled nursing care without going through a costly high-risk hospital stay. In other cases, we allow for case management through a home visit waiver, so for people to come into patients' homes. And in a third example, and I'll give an example of how we're using this, we allow for payment arrangement across participants that can really encourage and build sort of that systemic coordination. We also obviously use tools such as quality measurements tied to financial payment, and we often create specific requirements for care management to sort of instill certain changes in the way care is given in our models. And I'm going to use the example of our guide model to highlight this, and then I'll talk briefly also about a particular example in our lead model, just to show sort of how we can embed some of these authorities inside of our models to drive safety. And I'll be brief because these are just meant to be examples, but here's an image related to how in Guide, which is a ambulatory model focused on improving the care of patients with dementia that has many features to it that are really focused on supporting caregivers. But we also, within this, given the risk of polypharmacy for dementia patients, have a number of different factors in place just to focus on attending to medication management. So we have requirements for the physicians to review and reconcile medicines. We have quality measures that have financial incentives particularly focused on high-risk medicines. We have support for communication across the teams. We have the use of care navigators. So you see how we can start to build like many pieces that you need to really drive something like avoidance of polypharmacy. I'm talking a little fast, but I've got just one more example. LEAD is our newest ACO model, which launches in 2027, and there's lots that we could talk about in LEAD, but I just want to highlight one aspect that brings in an example of how our models can distinctly support patient safety. In LEAD, we're testing what are called CMS-administered risk arrangements, and this creates infrastructures for ACOs to be able to contract directly with specialists. And one of those specific mechanisms in LEAD is called RISE, which stands for Resilience and Independence in a Safe Environment to Age in Place episode. RISE is much easier to say than all of those words. But this is a distinct opportunity where ACOs can build actually on what folks may have known of as the capable model from some time ago. So they can contract directly to bring occupational therapists and nurses into patients' homes and focus on fall prevention. And when we create an opportunity like this for the ACOs, we're tying that also to a requirement that they have a new prevention intervention that we are tracking, and we're encouraging them to consider this as a piece of their particular prevention interventions. Okay. So I just want to also highlight the impact because in the Innovation Center, we also test what happens with our models. So here are a few examples of CMMI evaluations, again, in models that weren't proclaimed to be patient safety models, but where we had the opportunity to understand an impact. So I already talked about our episode-based payment models and how important it was as we're driving down post-acute care use and costs to build in looking at things like complications of care as a guardrail, and the success of CJR in maintaining quality while reducing costs. That's an important feature of our safety models. In our oncology care model, we had an embedded multidimensional safety framework that looked at things like unanticipated ED visits and late-stage chemo use, and those results showed an overall improvement in quality and safety. So again, an evaluation showing that the model led to improvements. And a favorite is the Partnership for Patients, which was an early model which where patient safety was really front and center. And this is credited with a lot of improvements nationally in things such as healthcare-acquired conditions. Okay, so in sum, I hope this is helpful for the committee to consider the range of tools that we have to advance patient safety in the Innovation Center throughout our models, whether or not we label them as patient safety models. And we can continue to use these authorities and are eager to hear the committee's recommendations for how to do so, especially interested in how we can build on the coordination functions that are so important for safety and have been found to be a feature of many models, and the incorporation of patient voice in this coordination. And there's a special opportunity when we advance safety in the CMMI models to do these at formal tests that we evaluate and therefore can expand when they're successful. Thank you.
Thank you, Susannah. Next, we are excited to welcome virtually Dr. Jason Mitchell, who is Executive Vice President and Chief Medical Officer at Geisinger. Welcome, Jason.
Thank you all so much. It really is a privilege to be here. I am a practicing family physician as well as CMO at Geisinger, and so this is near and dear to my heart. Go ahead and go to the next slide. The truth is safety matters, period, and zero harm is possible. And I think with all of us cumulatively in this room, representing who we represent, so CMS, health systems, clinicians, we can get to zero harm. And I just wanted to begin with that. Next slide. And I wanted to start with some of the great things that have been done. And so we use these models, we participate in these models, and there's a ton of opportunity here. And so it was really fun to hear you all talking about them because I think they've really moved the ball forward. I think there's also opportunities which I'd like to highlight. The first is, most of the CMS-driven alternative payment models really don't have a full incentive framework for safety on its own. It's mixed into other pieces. And we still have a focus in these models on utilization, admissions, readmissions, those type of things, which are really, really important, but safety goes far beyond that. I would say probably the strongest of these models, and we've heard about this, is the CMS team model, which really begins to dig into key safety metrics and is important. And as I think about the opportunities for this to go forward and thinking of these past presentations that we just presented, this was in there, medication events are huge in safety, right? Whether you're in the hospital, in the home, in clinic, medication is huge. Post-discharge falls. When you think about what begins that cycle for our patients, they get them to many admissions, it will be a fall, repeated falls. Post-discharge complications, so far beyond some of the bundles we've seen in the past, but really think about all admission types. And then ambulatory safety. Generally, people are not in our hospitals and they're not in our clinics, they're at home. And so how can we begin to address their needs at home? And so as I think about the current models, which have done a lot of great good for the people they serve, I think about here's the pieces we could be going to. Next slide. So I think it's not just obviously CMS's job to do this, it's our job as health systems to do this, right? We have to do this in partnership. We have to be pushing forward. This is an example of what Geisinger has done, where we were actually warranting some of our procedures. We are going personally at risk for any bad outcomes to ensure that we are aligned with the best outcomes 100% of the time. And this is an example of some of the work in Proven Care, which is a warranty in heart surgery. And it really, as CMS puts people at risk, we put ourselves at risk with different payers as well. Next slide. And in doing so, you really have to change your organization. And I want to share a little bit about what Geisinger's done as a health system, because I think this can play into what CMS can do and integrate into your models. But if you want to eliminate harm and get to zero harm, if you want to improve safety, you have to be highly reliable. You can't be great 95% of the time. You have to be great 99.999% of the time, right? You have to be that perfect. And to do that, you have to have systems to support you. For us, we are all in on high reliability organization principles. And I want to share a little bit about this and then how they impact what we do. There are really 5 principles to high reliability. The first sections are anticipate safety threats. The second is respond and adapt. So in that anticipate section, it's a preoccupation with failure, which sounds terrible, right? You don't want to be preoccupied with failure, but in fact, it's amazing. And it's what we do as clinicians every day. We're always worried, what could go wrong? What's happened with my patient? What can I do to preempt it? And it's getting that mindset for every individual that touches the patient to preempt and prevent. The second is a reluctance to simplify. Healthcare is complex. And it's never just, oh, we could just do X, Y, or Z and that fixes it. You have to dig in, understand root cause analysis, and truly get to the cause. The third is sensitivity to operations, meaning the people at the front line understand what's going on better than the people who are not at the front line. And so you have to understand and ask and be present to really solve for these safety issues. And the respond and adapt in an HRO system, it's a commitment to resilience, knowing that failures occur, and when they occur, how do you bounce back and prevent them again? You have to have that resilience. And then the fifth concept is deference to expertise. So as we are making decisions, as we are designing for patient safety, you defer to expertise. And the people most expert are the patients and the clinicians, the nurses, the doctors, the advanced practice clinicians taking care of them. And so having that deference to expertise and including them in the conversation and co-designing gives you a much better product. And these are the principles that we use every day at Geisinger so that we can work to zero harm, both in the inpatient and ambulatory setting. Next slide. To do this, you have to really change how you lead. And you have to make it part of the fundamental culture so that everyone's involved. As I mentioned, it's all about reliability, which is a consistency. There's things that you can do. What we do is we start every meeting with a safety moment. Every single meeting with a safety moment. And even if it's our health plan meeting, if it's administrative meeting, IT meeting, it's with a safety moment because it all ties back to care. And that keeps people focused on how what work they do ties back to it. We encourage and protect those that speak up. You've got to have a psychologically safe environment and transparency so people feel safe saying, hey, this didn't go right, or people pull the line when something's not right and stop something before it starts. You have to have a no-blame culture, and you have to celebrate when you find the harm because now you can find it, identify it, do a root cause, and prevent it in the future. So a very different way of thinking about it within a just culture. And then you have to link decisions to safety. In every decision you make, you have to think, how does this impact the patients that we serve? How will it change their safety? And how do we create reliability that we do this every single time? So those are the concepts as leaders that allow us to use those principles. Next slide. And so with that, that's how we have worked towards it. And I want to share some of the things that I believe that we could do as a health system, that CMS can do, and APM models that will advance us forward. The first is really advancing patient safety metrics to directly reward harm prevention. So adding the safety composite score for ACOs, considering a safety-gated financial incentive. So it's hard to get savings if you haven't also had safety. And I heard some other withholding concepts in the previous conversation. This is more of just a gating for the benefits of safety. And then beginning to think about bundled payments that include post-acute safety measures far beyond readmissions, because there's a lot of other important things that happen to create safety for patients prior than just readmissions. And so including the more comprehensive look. I think the second piece of this is aligning financial outcomes with zero harm. So can we anchor outcome-adjusted payments to safety? So really episode guarantees like we have done with Proven Care. Can we do that and go beyond just the basics, just the bread and butter diagnosis of populations? Another piece is rewarding bundle adherence. So bundle adherence is a leading indicator to harm avoidance. And some organizations have to ramp up to prevent harm. And so how do you create systems that align that allow people to ramp up with adherence and then eventually the outcomes measures so that they have that time to do that? And then the other piece is really, and you heard about this earlier, integrating patient-reported outcomes and safety measures. Because what really matters is what the patients feel, what people feel, what people experience. And we can say all we want, we can show all the numbers we want, but we need to know what they are experiencing. And as we ramp this up, we'll get a better sense of what our patients need, what we need, what our families need. And so including those. And then finally, and you heard little bits and pieces of this in other conversations, but really deploying models to support ambulatory safety, because that's where patients are. That's where people are in their homes, at work. They're not in our hospitals very much. They're out in the community, and that's where we can have a huge amount of impact. Probably the most important thing is getting an established framework. What are the unified metrics and outcomes in the ambulatory setting? Let's get a framework we can all align to, we can put incentives to, and move forward as a nation. I think that would be critical for us. I think the second piece is a focus on frailty and fall prevention. When I step back and actually look at hospital metrics nationally, locally, that frailty of that individual is a huge predictor to something bad happening to that patient. And if we can understand that, we can improve the nutrition, we can prevent the falls, you can fundamentally reduce harm for those individuals. And so that is a place where we have ripe opportunity that we've probably not taken advantage of as a nation to improve the health outcomes of people. And then finally, medications, reduce harm from medications. There are so many ways that medications do amazing things for us. There's so many ways they harm. Polypharmacy can be harmful, confusion as to what medications to take, lack of access to get their medications, confusion around benefits of medications. And so as a big category that can reduce harm, especially in the ambulatory setting, it's another place to look. And so really, I wanted to be brief. I wanted to share safety matters. We are all about zero harm. We've put a lot of effort into it. We don't call it preventable harm. We call it all harm. All harm's preventable. And even if you can't figure out how to prevent it today, tomorrow you're probably going to. So I really want to put that stake in the sand and then share some of these key opportunities with you all, and looking forward to questions at the end of this.
Thank you, Jason. Finally, we are delighted to welcome virtually Dr. Dheerendra Kommala, Chief Medical Officer at ECRI. Please go ahead, Dheerendra.
Thank you so much for the invitation. Excited to be here. It's a privilege to be here. If we can go to the next slide, please. Excited to represent the 250 passionate people who work at ECRI to really improve safety and quality in healthcare. Our mission and our vision is to reduce harm. We are a federally qualified patient safety organization. We are also an evidence practice center designated by ARC, one of the only organizations that is a combination of both. We've been a testing lab for almost 60 years now, testing medical devices and equipment. We also have, as a sister organization, ISMP, Institute for Safe Medication Practices. That is the premier organization in reduction of medication errors. And most recently, we acquired a company called the Just Culture Company, which is all about non-punitive culture to transform workplaces. We, as you can see here, serve a significant part of the ecosystem in many different ways. If you can go to the next slide, please. Thank you. Yeah, many of these topics have been talked about in the beginning parts of the presentations. We continue to make some progress through the different innovative models that CMS has proposed, but there still is significant areas of improvement. We continue to see 1 in 4 patients observing adverse events, 50% underreporting, if not more. There's a significant areas of improvement for us, which is we need to really change our patient safety outcomes. And really implement continuous learning systems, because the only way we'll get better is learning from things that have happened and implementing them. What I have done for this presentation is look at the last 10,000 events that we actually have been reported to us and gain some insights and make some recommendations. If you can go to the next slide, please. Okay, so the concept here is all about near misses. And I think Sam pointed out that it's about once we learn about something, we need to make sure that they're implemented appropriately. And it's not being punitive at the stage where events are being reported. So we looked at the 10,000 events that were submitted to us, and over 1,000 of those events were what are called near misses. As an example, a pharmacist was conducting rounds and found a heparin drip that a patient was on. There was no monitoring labs for almost 48 hours. Labs were ordered after 48 hours. This is a very classical case of a near miss where significant harm could have befallen the patient. But this kind of behavior is not incentivized, where this pharmacist in particular reported the potential that this could have caused a harm. So this is a recommendation that I will talk about later, which is let's reward safety signals. Let's reward near misses so that this becomes a culture for us. In addition to, obviously, if people are not implementing the right steps, then there should be disincentives. Next slide, please. One of the pieces that we consistently see is medication reconciliation problems. In particular, these transitions happen at admission, during inpatient care, and at discharge. Some of the earlier presenters have talked about this. almost 73% of these events that we've seen are taking place during care transitions. As an example, 6 medications that the patient was on was completely omitted at the time of admission. It was caught at the time of discharge. And these are medications like aspirin, thyroid supplements, etc., which actually are, as you can all understand, is problematic that there was no recognition of that. So transition failures do not have an accountable owner. And we need to set that up, and we need to incentivize the correct reporting here as well. Next slide, please. There's a big role for technology to play, I think, and I agree with earlier presenters that it could change the safety paradigm. But the issue is that there's almost 1,500 new devices that have been cleared through 2025. About 97% of them, significant portion of them, are cleared by the 510K process. And if you look at the recalls, there's almost 43% of AI devices have been recalled over the last 1 year. The point here is we absolutely need to utilize new innovative technologies, but it should be connected with outcomes. It should be connected with value-based frameworks. We are also supportive of enabling digital health access. Next slide, please. We've looked at sepsis as an event in the last 10,000 safety events, and we observed 88 sepsis-related events, 15 of them being severe. One thing which caught my mind is there was almost an 8-hour delay from the time the patient actually came into the hospital all the way to the antibiotic being administered. Now, there could be many reasons for it, but as we see this consistently, we see system design failures in the context of order sets being ambiguous, IV access barriers, antibiotic scheduling, and competing clinical priorities. So the point here is this is just a tip of the iceberg problem where there's a need for us to really look at systems design and human factors engineering to really address some of these systematic problems. And that needs to be incentivized as well. Next slide, please. Okay, so very quickly then, recommendations. Safety signals should be utilized, and in particular, near misses to adverse events, right? So you want a health system to decrease their adverse events and increase their near misses so that they actually get the right culture and the continuous learning system. We need to start incentivizing utilization of technology, but in a value-based framework, and outcomes should be an important parameter that we are actually measuring them on. Patient care transitions continue to be a problem, particularly in high-risk points, and we need accountability. We need payment structures that actually take into account patient care transitions. It's not just the acute care system anymore. It is the alternate care sites and it's the home. And finally, we need to start thinking about human factors engineering and design of care delivery. It's an important factor that goes from reactive to proactive. I want to end by saying the patient has to be at the center of all we do. Sue, Sheridan, I'm completely supportive of the concept that you put forth. Thank you for your time and glad to take questions.
Thank you, Dheerendra, and thank you to all our experts for these great informative presentations. Now, let's move to the discussion portion of the session. At this time, PTAC members, please flip your name card up, or for our virtual committee members, please raise your hand on Zoom if you have questions for our guests. Additionally, we want to encourage our experts to ask each other follow-up questions. You can signal that you have a question by flipping your name card up or raising your hand on Zoom. In the interest of ensuring balance across different perspectives and questions, we encourage experts to keep each response to a few minutes. All right, so Sue.
You know, I'm just learning so much in this, and I have a question actually for Susannah. Susannah, you mentioned that, you know, at CMMI you don't really have any innovation models that focus just on safety. Could there be models that focus just on safety?
Absolutely. I mean, that's the short answer. You want short answers?
Great.
I would just say the one thing I'll add is, like, I would not want that to distract us from building it into other models, because,
Yep.
you know, the ability to expand models, if they don't have a patient safety focus, if it's not that one, that gets expanded. So,
Yep. Thank you.
Thank you. I think David's next. Okay.
I think I was last to put it up, but that's totally fine too. So I actually want to go back to a point that Sam raised in his opening remarks, but I think kind of came up in a lot of what you all were talking about. And I don't direct this to one person individually, so whoever wants to sort of popcorn in, please feel free. But how do we engage the low performers? How do we bring them along? I think the point is well taken that anybody that's going to voluntarily participate in the CMMI model or watch a PTAC recording are probably the folks that are not the ones that we need to focus on. So is it focusing on improvement trajectory? How do we keep them engaged from the initial point of intervention and then the actual outcome, which sometimes can take years to sort of see that improvement play out? So I don't know who wants to take that first, but how do we engage low performers?
I can start. I will tell you, in the quality improvement organization network, we target low performers and we look at what their scores are and reach out. It's also a voluntary program, so they don't have to, but we specifically target low performers. And I think any other kind of model or payment system could do the same.
I'd like to add onto what Michelle said. Tomorrow I'm presenting the earn back model, the incentives conceptual model, and something that we're seeing, that if those who do not reach their performance measures, their benchmarks, that this is where we see a great opportunity for the QIOs to come in as consultants to help those lower performers rise up and then earn back their what was withheld. So we're trying to weave in many of the CMS levers into the earn back payment model.
and the only thing I'll add, I think I was going to say both of these things. There's ways to do it with the financial, there's ways to do it with quality improvement. Often the measures reward improvement, right? So we have a complicated thing in ACO REACH called CI-SEP, but part of the idea is that if you're not achieving, if you get rewarded for improvement. And then the last thing I'll say is that this is an issue with voluntary models, and you will see we are increasingly thinking about mandatory models so that you get a more representative set of participants.
Just one other thought on here is, meet people where they are. Let's assume that everyone wants to be high quality and they've got barriers to that. And so I think providing glide paths, sometimes providing incentives up front, so if they need to invest, they can, is important. And so let's assume good intentions, figure out the barriers, avoid simplifying, and then give them pathways that work. And I know there's many CMS models that do that, right? There's different tiers, there's different timings. So I think that's the best way to match the low performers.
If I can jump in, we meet with all CEOs and C-suite folks of both high-performing and low-performing organizations. The ability to connect safety and quality to financials is a gap, and there needs to be some level of education there, that if you're safer as a hospital, you'll actually end up being better in from a financial outcome standpoint. That piece, I think, is lacking. And then the second piece really is around absolutely incentivizing the right behaviors and providing the right financial output for the right behaviors that are being, and the right outcomes that they are achieving. Moving up levels, whether it's leapfrog scores or otherwise, they should be incentivized to do that.
Yeah, I'm kind of giving away my presentation tomorrow, but I'm just thinking about that, the earn back model, and I'll go much more into detail tomorrow, but we actually see it, the pivot earn back model, as a continuous learning system within a payment model. And so for low performance, what we envision as people don't make their benchmarks and reinvest, their withheld money into safety, and there's actual learning and improvement that gets shared with other hospitals. So almost like a partnership for patients kind of concept. So there could be a learning collaborative that's going on as hospitals are learning how to improve in safety. So it would help those lower performers.
Great, thank you for all those responses. I'm gonna go to Larry and then Lauren.
Thank you, Walter. Great discussion. As always happens here when we listen to our SMEs, the gears in my head are just flying. But thinking about what the commonalities are amongst the four presentations, one of the things I was very, very pleased to hear is a focus on ambulatory safety. So much of what CMS and CMMI have done in the past has been focused on the hospital side. But that's actually putting the cart in front of the horse, because the errors in safety, the errors in diagnosis, the misdiagnoses, they occur in the outpatient setting predominantly. And by the time the patient reaches the hospital in potentially an avoidable complication, we've really missed our opportunity. So I was very, very pleased to hear several of you speak about proactive patient engagement, especially in symptomatic high-risk chronic diseases. This has been something that's been near and dear to my heart for the last 10 years with my sonar work. And so I'd love to hear some granularity from you as how you have built PROMs and patient safety measures in the ambulatory space. I'd love to hear some granularity here.
I think that question was directed to me, Sue Sheridan.
Any of you, but Sue, go ahead.
I'll jump in. So the PROMs and PREMs that we have developed around safety and patient safety and diagnostic safety was really, we created a new methodology where we brought in over 100 patient organizations, community-based organizations. We brought in 3 separate populations: mothers of color, people with disabilities, and older adults. And together, over a series of 9 different engagement events, we created the PREMs and PROMs that mattered to the patients and family members. And then went through a very systematic and rigorous qualitative analysis of those. And then we mapped them onto national initiatives, patient safety initiatives, such as CMS, CDC, HRQ initiatives, and we narrowed it down to a set of 18, and then the stakeholder groups and the patients prioritize them. So we have come up with probably one of the first sets of patient-reported outcome and experience measures around safety and diagnoses, and we have more in the pipeline.
And how do you deploy them?
Right now they're getting piloted and validated by Press Ganey, and so they're under a validation process right now. And then we hope to deploy them through payment models. We hope to integrate them into the HCAPs, and so we hope to put them in play, work with CMS, and incorporate them as performance measures. So we see several pathways for the PREMs and PROMs around safety.
Anybody else want to comment on that? Anybody from the CMS, CMMI side?
Actually, I still think we have a lot of opportunity to have more insights into the ambulatory side. Statistically speaking, there really is probably a lower percentage of errors because there's not, an acute change in patient's condition as it is in the hospital setting. But we have started looking at diagnostic errors. CMS has introduced 2 diagnostic errors, one around timeliness of mammography, making sure that abnormal mammograms are followed completely and on time. Same thing for colonoscopy, because we know that is an area of real challenge. So we are starting to incorporate this. We have a commitment to look at patient safety measures and incorporate them in all of our value-based programs. In other words, those 27 value-based programs that extend into all care facility types.
Are you following up on the positive first-line colon cancer screening tests, because we're seeing dismal follow-ups for colonoscopy following someone who has a positive FIT or a positive Cologuard, because it's not part of the HEDIS measure, it's not part of the star rating.
That's exactly what's in one of the new measures that's being investigated.
Wonderful. Thank you.
All right, Lauren?
First, I want to just, I think I'm freezing. I'm going to have to turn off my camera. Apologies, I'm having Wi-Fi with weather here. Just want to commend all of you. Your presentations were all excellent in a lot of different directions. And specifically, Sue, I just want to commend you for transforming what happened with your family into advocacy for millions of people. I really have some specific questions. I've worked for more than 20 years in complex populations and hospitals, as well as in the ambulatory setting, definitely serving complex medical conditions, also children with complex needs. But another population that comes up in that field is those with behavioral health conditions. I was part of the National Academy of Medicine High Cost, High Needs collaborative, which really teased out the impact of behavioral health on high cost, high needs. And I'm just curious if each of you might comment on how do these measures apply, and how are they being looked at in the behavioral health population, which experiences the same complications with transitions in care failures, lack of evidence-based care, or overprescribing, and also unnecessary high utilization.
It's a great area of focus. I'll say just a quick word about our innovations in behavioral health model, the IBH model at CMMI. One of the things we're thinking about there, which touches on some of what you're talking about. So first, one of the key things about that model that I think is important is that it's really about how do you integrate the physical health care with the behavioral health care. And that alone, I think, creates a little bit of a safety net for the kinds of things that can happen in a setting if you don't, often patients with SMI don't necessarily have as a good a system for their physical health. So that's just an underlying feature. But maybe more importantly to your point is thinking about incorporating the patient voice in that model and how to think about patients' own goals as a feature of the care that is being required in that model. It's not exactly what you were asking about, but that's the place in the Innovation Center where we've most focused on some of the behavioral health needs recently.
Yeah, I'd like to comment. I think we have huge opportunity with BH, and you can't separate behavioral health from physical health, right? We're all one human. And if you look at the spend and utilization, if you have a BH diagnosis and any medical diagnosis, you're going to have about 2 to 3 times the utilization for that medical diagnosis when there's a concomitant BH. And so you can improve someone's health overall, both mentally and physically, if you treat it. We will never have enough psychiatrists, psychologists, therapists to treat all the folks with BH diagnosis if we don't get more people doing the bread and butter, depression, anxiety, and substance use disorder. And so as I think for the opportunities, if we could get more of the ambulatory clinicians that are not BH to treat depression and anxiety and SUD, it frees up the BH resources to do more complex things. And I think that would be transformational. Otherwise, you have a lot of folks with treatable illness that just can't get care. And so for us, we focus on collaborative care models. We focus on broad use of primary care clinicians and specialty clinicians to engage in BH diagnosis, both diagnosis and treatment for simple things. We engage clinical pharmacists to support us, but it really is creating a network for those simpler diagnoses that any of us can treat. Let's treat them. And they are not just BH and they're not just psychiatry. If you have a heart attack or a stroke, there's a great increased chance of depression afterwards, right? We know it's there. It's part of these processes. Let's treat it. If you look at postpartum depression, it's super common part of pregnancy. Let's diagnose and treat it in those specialties. So we've got to have specialists engaged in their specialty, also treating it. And I think that's how we get from here to there on a lot of the BH conditions that we see.
If I can comment, Lauren, as well. So we see events related to lack of timely follow-up post-discharge. we see the same issues we see in other faculties of medicine, which is around med reconciliation. I think for us to think about making sure that there are incentives for timely follow-up. Jason brought up postpartum depression. I mean, one of the issues there is, can we have timely follow-up so that we detect it appropriately and treat it appropriately? Med reconciliation is another big issue, and it is obviously pervasive across all kinds of discharge. And in this aspect, really, patient and family education is very critical to identify sort of the red flags that actually they're probably going to see. And so, yeah, we need to look at this systematically across all these domains and ensure that they're appropriately incentivized.
I'll just add, this is Sue. I'll just endorse what you just said about the importance of patient and family inclusion in identifying what matters most to the patients, and also what could those prems and proms look like from the behavioral mental health point of view. Now, some of the questions that are we call them pivot questions, address some of that, but we would like to down the road, we're creating a pipeline. We would like to do something around behavioral and mental health specific, because we think some of those questions will be nuanced. So we hope to put those into the pipeline.
Thank you all.
So I'd like to turn to Krishna. Thank you for your patience.
No worries. Thank you. Yeah, excellent comments, discussions by all there. This is a question for Michelle, but open for other panelists as well. Michelle, you mentioned the role of AI for identification and deeper understanding of harm. I definitely believe in the potential of AI and certainly some of the risks as well that Dheerendra mentioned. Could you elaborate on CMS's thinking about it? How can it come to life safely and responsibly from a care delivery perspective?
Thanks for the question. I think there are a lot of opportunities. One of the things that we're doing is, again, looking at if there's an AI engine on top of a facility's electronic medical record, can they be using a large language model and pulling information from text-based documents for radiology reports, for example, pathology reports, the clinical notes, because there's so much information that is there, but it's not just coded data information, it's unstructured data, and that's where a lot of information is. So I think there's a tremendous opportunity there. But of course, we have to make sure that the AI systems are correct and are pulling that appropriately. I think one of the other challenges in safety, and I alluded to it, is that the incident reports, for example, in most organizations are not directly under the purview of many of the quality organizations. Some are seen as risk and risk management, and that is directly distinct from quality and quality management, and we don't always see that. So I think AI is an opportune time to look at that as well. In addition, I think AI is going to be helpful when it comes to predictive models, monitoring, like you can monitor an entire unit, for example, looking for early warning signs and then intervening early on patients who may need it. So I think it is going to really present a lot of opportunities. I do want to make one comment, though, and that's, we've spoken of digital measures so that people can use them in real time in a facility. We actually aligned our initial digital measures with ECRI, thank you very much, on the most common types of harm. The problem is we start turning those on across organizations, and I think you're going to hear this from David Klassen later when he speaks, is that you suddenly get this overwhelming volume of errors that you find out, to the point that some organizations that have started doing this have turned these systems off because they don't know how to deal with the quantity of information that they're getting, which leads to what I had spoken of earlier, the capability in a system to be able to process this. And I think AI is going to help with that as well. So if you're getting all of these volume of events, can you use AI to help you evaluate them and prioritize them? Because I'm very concerned that, again, some very big systems have turned these off.
If I can add to that as well, there is an opportunity for us to capture near misses in this manner that maybe we will not be able to capture if there's no AI overlay. So using LLM. So I think it's all about the continuous learning system for the ability to capture it. But Michelle's right. if we are capturing a lot of information, we need to decipher it and make sure what is relevant and important is actually captured and acted upon. But the near miss concept can also be captured through AI overlays.
Yeah, just to add on to this, the democratization of information to the point of care is critical, and it's something that a human brain can't always do. So I'm a family doc. I can't read 1,000 things in the chart. I can't read every hospital admission. I can't read every study and know it all at once. We do the best we can. That's how we operate. With AI and chart synthesis, it should give me a better picture than I could ever do on my own. And if you begin to give that tool, not just to your doctors and your advanced practice clinicians, but every nurse for phone triage, every time someone calls into the help desk, every time someone calls anyway, and they now have a bigger picture, it should help us identify and prevent the harm before it happens and to see those near misses. And so I think there's a huge opportunity here. And I am all about, let's go to the big level, let's throw it over the whole system and find it as a system. But if we get every clinician, every nurse, everyone on the phone working to prevent harm because they have the tool at their fingertips, I think that's how you really move the ball. And that's the structure you need to deal with probably the amount that's out there that we haven't seen.
I would add another person to your list that you just mentioned. I would add the patient. The patients are becoming extremely super users of AI, and we have the opportunity to contribute to safety. So just imagine if patients were, let's say in a healthcare system, let's say in a hospital, they had, access that, let's say a bot, reaches out to them every night at the hospital, asks them 5 questions about safety. That could immediately give, immediate feedback and alerts to like deterioration or being dismissed or seeing unsafe care. And so the opportunity to automate and use AI to capture from the patient what is going on, it could definitely feed into a safer healthcare system. And Michelle was talking about predictive analytics. Now, if there is, an engine operating the background, think about Cal. Had there been AI operating the background, they would have seen a neonate at 16 hours already jaundiced. That is a red flag. It should have set off alarms. And, at discharge, head to toe jaundice, 33 hours old, discharge, AI should have set off alarms. But what if it set up alerts to mom? What if on my cell phone I got from this AI system, Mom, your child is in danger of, elevated jaundice, don't leave without a bilirubin test. So you think of all these really creative opportunities to engage not just the doctors and nurses, administrators, but the patients.
Thank you for those responses. Lindsay?
Yeah, thanks. I don't know. We were riding the AI enthusiasm, so I almost feel like I'm taking away from that. But maybe the answer can incorporate some of it. When we think about other challenges certainly in the physician world and everywhere, administrative burden, reporting burden is still very top of mind. You layer that on to flat payments, and so I've heard a couple different ways to fund these improvements in safety. I heard, thinking about, or ways to accomplishment, I should say. So, Susannah, you highlighted the idea of promoting process measures that improve safety, medication reconciliation, proven things along the way that maybe don't have a cost, but the measurement is a little bit easier. I also heard people talk, though, about penalties and withholds, and my worry, to maybe David's leading question, is when we think about the people with the biggest opportunity to improve, and we're talking about mechanisms like withholds or even just penalties for safety, I'm worrying about, again, if we're hitting the most vulnerable with more potential reporting costs and burdens and potential reductions in payment. And so I guess as you think about the different ways to accomplish the goal of safety through funding mechanisms, I heard kind of incentivizing process measures, which already exist, that support safety. I heard maybe paying for new tools, AI or otherwise, that support safety. But then I also heard kind of the more traditional penalties and withhold. And I'm just kind of curious, as we think about where we go, do we think that penalties and reducing payments or increasing the burden of reporting is enough, or are there other ways to support this goal outside that?
I will comment on that as a healthcare system. I think shared savings works great. We know quality and safety reduces the cost of care, which it reduces the cost to CMS and to us as a national community. And so when we reduce harm, there should be savings we can measure, and we can share that savings back with the systems that do it. If you take systems that are struggling today on CMS metrics, and if they have mostly Medicare and Medicaid and can't make ends meet, doing a withholding and expecting them to invest is unlikely to be successful. And certainly if it's a voluntary model, no one's going to participate. If it's a mandatory model, you just gave them a pay cut to someone who's having challenges. So I think really if we could get more into a shared savings and say, look, every time you prevent a readmission, every time you prevent a fall, every time you just stop the hip fracture, there's shared savings and it's real money, then that's how everybody wins, because it decreases overall utilization. And so as a hospital system, yes, we have less people harmed in the hospital, but that's great. And it shifts that funding that would be spent in hospitalizations to fund these programs. So I really would like us not to do a withhold from fee for service, but actually a shared savings on what you could do through quality and safety.
The only thing I'll add is that I think Michelle has said this a couple of times, but as an agency, we're thinking a lot about, the way measures can function and be good, but are not the be-all, end-all of improvement, right? And so this concept that Michelle was talking about of sort of how do we support capabilities, how do we assess and reward capabilities is one way of starting to sort of build that fundamental layer. And that can look different if you're talking about a hospital versus an ambulatory setting. But I think that's an important direction that we are thinking about a lot. And the other thing in the models, the other tool we have, and in many of them we use these, are sort of ways of doing prospective or early payment, including some of the models having multiple years of pre-implementation where we're really supporting, and this happens like in the state models with Medicaid, where we're really supporting some of the system transformation that has to happen before those sort of incentive pieces come into play. So just two thoughts that I think are important.
A couple of things. I would say even in the traditional Medicare models where there is a withhold, paying back if there's improvement, right? So there has to be a way of being able to, what Sue was talking about, earn those dollars back. The second I would say is in reducing the burden of some of these programs. The part of the gist of the transition to digital measures is that they are 1/20th of the burden that's been shown in a couple of evidence-based studies. And then the timeliness of information, which allows for real-time learning and improvement, I think becomes payback at that point.
Just a prequel to all of that is if all the EMR vendors must have ECQMs built into them with workflows, it makes it easier for systems to do that, and even the smaller vendors, so that you have all the independent doctors and smaller practices that don't have the epics that can participate as well. And so there may be another piece to consider in the recommendations on what's expected of these EHR vendors to facilitate this work.
Well, great. Thanks for a really robust discussion. We are 5 minutes past the official end time, but we got started late, so we'll just call it even there. I'd like to thank all 5 of our experts for joining us today. You helped us cover a lot of ground during the session, and you're welcome to stay and listen to as much of the meeting as you'd like. At this time, we have a break until 1:10 p.m. Eastern Time. Please join us then. We have a great set of experts for our second session, which focuses on measuring patient safety in value-based care. Thank you.
Thank you all.
Produced by the U.S. Department of Health and Human Services.